Still good? Do you guys see them on everybody? Seems like any ultrasound I send somebody for, it comes back with a UAR on it. If we are assessing uterine artery Doppler studies, usually it's a once-a-week test that they do with the biophysical profile. However, if the test, if the results are elevated and they seem to be trending towards being elevated, then we might increase the frequency of the testing, right? They might be getting them a couple times a week, even sometimes more than that. So if the test results are becoming more and more abnormal, which is kind of what happens, they tend to trend that way. You kind of watch them, the number is getting higher and higher and higher, and then pretty soon, it's weird how this goes, but pretty soon actually the number reaches 0 and then it goes backwards, right? So 0 is kind of bad, meaning absent end arterial flow, and then you get negative values, reversed end diastolic flow. Does this make sense? I don't know what I'm talking about here if you use these. Okay. In any case, anyone having umbilical artery Doppler studies really should be delivered by 37 weeks, right? That's recommended. IUGR and preeclamptic patients all would be delivered at 37. So going beyond 37 probably typically is not also indicated. A high or increasing Doppler study if the patient has end diastolic flow. High or increasing Dopplers. We're going to increase fetal surveillance, as I said, once or twice a week testing, and then if there is any further evidence of compromise, she would be delivered. But all of these, again, are going to be kind of situation-based, like what the rest of the story is, and gestation comes into play. In the absence of end diastolic flow, that's abnormal testing. Generally, she's going to be put in-house. There's going to be continuous monitoring from that point on. She will be delivered depending on gestational age. If there is reverse end diastolic flow, it's emergent delivery. Those babies are stillborn within 24 hours. I want to say it's something like 70% of them. So once they have reversed end diastolic flow, it's urgent delivery. If they're greater than 28 weeks, it's immediate. Does this all make sense? So that's kind of our order of technical testing. So we're going to use all that to prove that our baby is oxygenated and we can safely maintain this pregnancy out to 37 weeks. So she's going to be having weekly testing. Things that are not beneficial, if the patient does not have severe features, it is not beneficial to put her in-house on bed rest. It is also not beneficial to put her on medication for this, right? So if she does not have a severe feature, we're going to be doing outpatient testing and try to get this to 37 weeks, and then we will be moving towards delivery. Delivery is recommended at 37 weeks because we're going to try to get her delivered now before a severe feature comes, right? Where kind of in the past we've looked at it a little different, like, well, she's 37, but she's still kind of stable-ish. Nothing else is going wrong, so we're going to sit tight a little bit longer. Hopefully she'll have a better chance for vaginal delivery if we wait a little bit longer. Now they say none of that. At 37, you don't want to wait for something else bad to happen. It has a negative impact on outcomes. And also higher chance for vaginal delivery at 37 weeks than beyond 37 weeks. Going beyond 37 weeks, increased chance for a C-section for uteroplacental perfusion problems. The placenta is not going to hold up for you for the labor. So actually you're better off for vaginal delivery at 37 weeks as well. If she is less than 34 weeks and develops a severe feature, we may delay delivery for 48 hours, right? She could use those steroids for sure. The baby would benefit from that. So we would delay for 48 hours if she met all these criteria. She wasn't oligo. Basically, this patient, who it's going to be, not in HELLP syndrome, is somebody, her severe feature is her blood pressure. She's hit the blood pressures of 160 over 110, so they would medicate her down. If everything else is stable, get the steroids in, 48 hours later, deliver her. Meanwhile, oftentimes the baby does not tolerate the pressure being down. They get sectioned out anyway. But we would attempt to get the steroids in less than 34 if she qualified. If she is more than 34 weeks, she will still get the steroids out to 37 weeks, but we would not delay for the 48 hours to get the steroids in. Do you know what I mean by that? MAG is indicated for anyone with severe features. Consider transfer if you're not at a tertiary care. This is probably a high-risk patient that should be transferred to tertiary if you can transfer her. Consider the need for blood products. They have a high chance for postpartum hemorrhage. Also, HELLP syndrome has increased risk with this, and DIC increased risk with severe. And then if her pressures are greater than 160 over 110, she's also in hypertensive crisis and needs medicine for that. Anticonvulsant therapy then, so MAG, right? We use MAG as an anticonvulsant. MAG does not, okay, well, first of all, why people have a seizure with preeclampsia, remember it's the cerebral edema in there. They're super hyperstimulated now. MAG is almost like a sedative. Basically, it quiets them down. It does not cure the edema thing. It just makes it harder to have a seizure. So MAG is indicated for people with severe features. Some people MAG all their preeclamptics. The evidence is not as strong on that as it is for MAGing severe preeclamptics. So ACOG recommends MAGing severe preeclamptics, not other non-severe preeclamptics. If you are MAGing somebody, typically then we will leave that MAG on for 24 to 48 hours postpartum or until they diurese, right? Most places do 24 hours. However, once the patient diureses, she has cured that, right? So she could really have the MAG off then. And flip side also true, if you're hit 24 hours and she hasn't diuresed, you really probably should not discontinue the MAG yet, because that's what it's all about. Diuresis is the best sign of cure for preeclampsia. Other things to consider, like the dosing of MAG, 4 to 6 gram load is fairly typical, and then 1 to 3 grams an hour. There are studies that say a 2 gram load and running her at 1 gram an hour is just as effective. Outcomes are the same. MAG levels and keeping patients in therapeutic range is very controversial right now because really they have the same benefit whether they're subtherapeutic or not. If they're on the MAG, they're protected the same either way. Also, they say that if she is on the MAG, and she needs to have a C-section, you should leave the MAG on in the OR. So, yeah. Are you shutting it off? Anesthesia. I know. So really, if you're running MAG on someone, you should put a second line in them so that anesthesia has their own line to use. Also, there's some thought, like what about risk for postpartum hemorrhage if she's on the MAG? Postpartum hemorrhage is actually more likely with vaginal deliveries, and we don't shut it off for that, right? Because she has a risk of having a seizure. We don't reload them after their surgery or something, so then really they have lower levels. You could kind of argue that one too. They're supposed to have it, and people seize in the surgery. So this is all defined by ACOG. They should not have it off during their surgery.
You said there's no benefit to checking like the MAG level in the urine?
Studies would say no to that, unless they're symptomatic. If they have symptoms of MAG toxicity, obviously they need to have their MAG levels checked. But like routinely checking them and increasing their MAG based on what their level is, there is no benefit to that in the literature. I know, we've always done it that way. Mm-hmm. Oh, you decrease it based on the levels.
Start off at one level,
Yeah.
and then decrease it if the MAG seems
And that, I'm definitely not saying that's not useful. If you think the MAG level is too high and she's symptomatic from it, for sure, they're going to maybe check MAG levels on her. But what I'm saying is trying to keep people, like, for example, well, actually, that same doctor I was just talking about, super particular about her MAG levels. Even if the patient has a really high MAG level and she goes in and checks her reflexes and the patient's kind of hyperreflexive, she'll still crank up the MAG from it. None of that is useful. Any MAG the patient is on protects her from a seizure the same. It doesn't matter if she's on heavy doses or lower doses. In most patients, it's all going to come out in the wash. I think back in the day, we used to look at it differently, like there is a therapeutic range, we should try to keep her in this, but studies don't show that. Does that make sense, even if you don't like it? Yeah. Yeah. Yeah, once she diureses, because remember why she's on the MAG, really is to protect her from a seizure, but she would have a seizure because she has edema, cerebral edema, that's what causes the seizure. So once the patient diureses, she has cured the edema, she really doesn't need to be on the MAG anymore. Right.
So you can just continue for 24 hours?
We say 200 an hour for 3 hours. Other places use a different protocol of 4 liters in 24 hours. I would say, we say 200 an hour for 3 hours, but really it's like you go in there and the Foley is full. All of a sudden they are just dumping it out. Yeah.
Now, I went to another conference we had about a year ago and went back to an OB meeting there discussing the case. And I said, well, can't we stop it in 3 hours? And they said, oh, that's old school shit.
No. No, that is totally current. For sure. In fact, I would say more people are going to this now. It was the first trial that came out on this. Do I even have it on here? Yeah, Ehrenberg in 2016 put out the 200 an hour for 3 hours, and now the newer stuff is actually this 4 liters in 24 hours. So that definitely is not outdated. That's super current. 4 liters in 24. The Ehrenberg it was 2006. Yeah. So this has been around for a while for sure.
We routinely keep them on 24 hours plus bars now.
Well, and I think the whole 24 hours thing came because theoretically, most people will have diuresed within 24 hours. So rather than trying to, calculate it, we'll just say 24 hours. Another component of this, though, right, is the opposite, where if they have not diuresed, you should not shut the mag off, right? So kind of the same deal.
So, I'm sorry, and you might have said this, and because I don't pay attention all the time. Is there a certain, so when you say diurese, how much are we, it might be easier for people to say 24 hours too, because you have to set some kind of criteria. And there's one
Right, well,
criteria
that's
that
the
everybody-
criteria. No, there's just studies that would say kind of what's a threshold. So we say 200 an hour for 3 hours. That was the stuff that came out 10 years ago.
Okay.
We still go by that one. The later stuff says, 4 liters in 24 hours, you could shut it off, which would put everybody at least 24 hours. But then they're also saying with that one, if she hasn't diuresed that much, you shouldn't shut it off.
Right. So you still keep, it's still kind of, if you base
There's still
it on that, it's a
parameters
24
either
hour
way. Yep.
Period, so.
Does that all make sense? Kind of, sort of? Okay. Where I would direct you for that too, do you guys use Up to Date online? Yeah, look on there. They'll give you a bunch of resources for it too. Vaginal delivery is strongly preferred for preeclamptic patients. They should have a vaginal delivery. It's a crappy patient to take to the OR, right? They already have blood pressure issues, which anesthesia can affect. They already can have little coagulopathy things going on. They already got neuro stuff going on. It's not a good patient. Now major abdominal surgery on top of that. Ideally, we would try to avoid that if we could. Epidurals are also strongly recommended for preeclamptic patients. They should get an epidural. The problem with it, of course, is why an epidural? Because you don't want them to have general. They're super hard to intubate. They got all this edema, plus the general is really hard with their blood pressure stuff. So we want to be able to anesthetize them also for labor pain management. But what they say is, on admission, you should check the platelets, right? Because if their platelets are adequate, you should just put an epidural in them. Even if you don't dose it, bolus it, just leave it in there so that you have a means of anesthetizing her. Epidurals with thrombocytopenia, the problem with that is you can have an epidural hematoma, right? Which happens when they go to put it in. If they break little blood vessels there, which probably happens, normally we have enough platelets, you clot that off and that's the end of it. But if you have super low plates, it can bleed and get like a little pocket of blood, which pushes on the spinal cord and causes permanent paralysis. So we don't want that. That will happen when they put it in, it can break the little blood vessels. When you pull it out, it can break the little blood vessels. So you don't want to put it in with thrombocytopenia, you don't want to pull it out. But once it's in there, if her platelets go down, you're golden, right? It's already in there, it's all set, good to go for you if you need it. So you check their plates before you put it in, you get it in there before their plates get too far down, and then before you pull it out, you would recheck their platelets. Good? Know what I mean on that kind of? Okay, then we talked about that. Eclamptic patients mean that they were pre-eclamptic and now they had a seizure. They are no longer pre-eclamptic, now they are eclamptic. It happens about 1 in 50 with severe features, 1 in 400 without severe features. This is why ACOG says we're going to mag those with severe features, not necessarily the others. So management with eclampsia, kind of first of all, is like the nursing 101 component of it, stabilize the mother, right? Ideally, she's going to have a seizure. It's scary. Everybody kind of freaks out for a second. You're going to put her over on her left side, give her some oxygen, protect her airway, provide for safety so she doesn't hit her head on something, basically. Eclamptic seizures, important note about these, they are not like status epilepticus. Eclamptic seizures are self-limiting. It will stop itself. So she's going to have a seizure and then it's going to come to an end. So it's not like she's going to just like seize on until we do something about it. It's going to stop on its own. So we're going to provide for some safety here. And then we know now if she was not on MAG, it's bad, right? She is in bad shape here. She needs to be on the MAG, because now what will happen is she's at increased risk for having some more, and each subsequent one she has, worse outcomes for her and the baby. So once she has one, if she's not on MAG, she needs to get loaded up with some MAG. So she needs like a 6-gram load. If she's already on MAG, they say give her another 2 grams and top her up a little bit here. And then we have to consider like what's our best route of delivery if she's having seizures. If she has prolonged seizure, or if she's having multiple seizures, then you could also consider lorazepam, though that will not be indicated for most people, but lorazepam could also be considered. Has low fetal effect to it and a long half-life. So you get kind of a lot of bang for your buck out of that one. Following the seizure, we should really assess the mother's well-being. So we really should check some labs before we're going to like rush her back to the OR. But unfortunately, following this episode, then she will also have an issue with heart tones. So we get the seizure, we get past that, everybody's like, okay, maybe we're okay, and then you look over and the baby's womp, 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 womp. This episode of fetal bradycardia that's well established in literature, about 5 minutes is typical, down to 60 beats a minute even, I'm sure even lower potentially, but that's pretty average, and it persists down there. And it is well established, well documented in literature that that is going to happen, so you should expect it. There is going to be a bradycardia now. Probably we are whisking her now back towards the OR during this, right? But oftentimes by the time we get to the OR, they connect the monitor back up, the baby has recovered from it, then ideally we would not forge ahead with the C-section right in that moment. We would recheck the mom's lab, stabilize everybody, and then consider the best route of delivery. They say, however, that if it really happens, 20% of people have a vaginal delivery, not because they needed a section necessarily, but because we freak out over it. We don't tolerate the seizure. And I don't know how it is for you guys, but in my hospital, if we make it to the OR, she's probably getting a section. It's not too often. They're like, okay, false alarm. We'll just go back. I mean, right? Right, so yeah, that has come up before. Like theoretically, it seems like it would be risky to have her pushing during that time. So I think it really has to be individualized. This could be a case like for a operative vaginal delivery potentially to help her. She could do open glottis pushing potentially. But this is why they say people just aren't up for it. It seems to. I've ever had 2 patients seized now. The first one I had seized while she was pushing. She was literally crowning like that. Has a seizure. Unfortunately, a seizure is not like when they start puking and it like pushes it out. Yeah, no luck. It totally does. It totally sucks it back in. She had the seizure, right back up where it was like that, and now she was like maybe +2. We had the bradycardia. The doctor came. Actually, the bradycardia was passed by the time the doctor got there. And then I was like, can you do a vacuum, though? Maybe a vacuum, forceps? And he was like, are you out of your mind? She was, well, first of all, she's post-ictal now, so she really can't help you at all. The baby seems like it's way up there now, and plus she just had a seizure. My God, everyone was like, she needs a C-section. So she got a C-section. But like it's cases like that where really it's probably in her best interest, right? Recheck her lab, stabilize, reload her with the MAG. She actually wasn't on MAG, so she needed the full 6 grams. And then consider the best route of delivery. It's right there. Do you really want to take her to the OR now? Who wants her? No anesthesia wants her now. I can tell you that after she's seizing already. So consider route of delivery. That's what they say. HELP syndrome is a form of severe preeclampsia. Hemolysis, elevated liver enzymes, low platelets. 70% of people who have this piece of it get it during the antepartum, usually preterm. And 30% of people that get HELP syndrome actually develop it postpartum. Super weird because the placenta is out. So why is this happening now when the placenta is already out of them? The theory on that, and it is that a theory, is that could it be that during labor, or possibly during the delivery, because some people will get postpartum HELP after a C-section. So is it either like the stimulation of the contractions on the placenta, or somehow when the placenta releases, does some of that S-flit and endoglin somehow or another end up getting ejected into the maternal side, like almost like a bolus, and then all this stuff happens postpartum? The other theory about postpartum onset is, could it be really that they had it and it was like subclinical, and now the stressors of labor, whatever, now it's going to become fulminant postpartum. 20% will not develop hypertension with HELP syndrome, and 20% will go into DIC. Big issues with HELP syndrome, the most common things are preterm delivery, 70%. Abruption is the number one for fetal death, abruption, and early prematurity. Maternal death, about 1%. So management for this, everything that goes for severe preeclampsia also goes for this, with the addition of consideration of her platelets and at what point should she be transfused. If the platelets are less than 20, they say she warrants a transfusion. If they're more than that, there is no point of transfusing her. You can't keep them up anyway, so it will be this whole process where she's just getting repetitive platelet transfusions. If she has to go to the OR, they need to be 40 to 50,000, so you would transfuse her up to that. And then, like I said, it's not like RBCs, right, where you just give her the platelets and we're good again now, because she will keep using up the platelets, the same process that used them up to begin with, so it will be this process till the underlying issue is resolved. If she has preeclampsia, the first 24 hours postpartum, people tend to exacerbate their symptoms. So people will tend to actually, got a sneeze coming. No, excuse me, thank you. First 24 hours, sometimes their pressures want to get higher on you right after the delivery, which they say is related to the stressors, the physical stressors of the labor. So we're going to keep close track of that. Who needs to be put on MAG postpartum? Like they weren't on it before, and now should we put them on it postpartum? There's rules about that. What they say, new onset of any hypertension, new onset with neurosymptoms, you got a MAGger. Or if she has severe hypertension postpartum, even with no other symptoms, she needs to be MAG'd. Sometimes people will end up going home with elevated blood pressure because at some point all their labs are normal, everything is normal, and then we're questioning, is this actually going to turn into some kind of a chronic thing? So they'll end up going home on meds. If they have preeclampsia diagnosed antenatally, they are supposed to come back postpartum 7 to 10 days after they deliver to have a blood pressure check. So the purpose of this is to try to avoid people coming back like 4-6 weeks later by ambulance through the ER because all of a sudden they've had the seizure at home. It didn't happen. It didn't just start 6 weeks later. It's been going on that whole time. I don't know if you guys notice this or not. We have way more readmissions now than we ever did before, but it's because we're looking for it more now. So all those people that would have just resolved it if you just left them alone, now we're trying to avoid having the ones that don't resolve. So we're doing more assessment of it. As far as future risk, anybody with preeclampsia has an increased lifetime risk for cardiovascular disease. There's some injury that happens that they say probably isn't like fully recoverable. Is there even like some little scarring in there? Something doesn't work right afterwards. So increased risk for that. And the recurrence rate for preeclampsia is somewhere between 5 and 70%.
That's so
You might get it. Yeah, I don't know. I have to take this word mild out. That does not belong there anymore. But what it is if she did not become severe and delivers at term, there's like a 5% increased risk. And then if she delivers early and had severe features, it's like a 70% chance. So you have to kind of plot your patient on there. You can reduce the risk by spacing the next pregnancy closer. Sooner the better for the next pregnancy. It's because of those uterine spiral arteries. Remember, they didn't open all the way. When the placenta comes out, they don't like collapse back down. They take time to remodel back down over time. If you conceive when they're still a little bit open, then theoretically the next trigger should get them open just maybe even a little bit more than that, so you can have better perfusion of that placenta. I went to a conference, Carl Monchi actually spoke on this, and he said those spiral arteries are kind of like pantyhose. Once you put your leg in, they never fit back in the egg. And me and one other person knew what he meant, which was really sad. I don't know how he knew either, but it was interesting. Right. If you don't know, my young little friend, back in the day, pantyhose used to come in this egg-shaped plastic thing. Legs, sheer energy. Loved those things. Control top, nude toe, suntan. Oh yeah, you love those things. I wondered that too. And he's young, so even weirder, but he's from India, and I kind of wondered, in India, do they wear pantyhose still? Maybe more? No. Oh, well, who knows how we knew then? He knew, though. Legs, pantyhose. Somebody, well, maybe he likes them. Who knows, right? Our next topic will be trauma. Trauma in pregnancy. What's the most likely thing you see for a trauma? What happened to him? Car accidents? Right, that's what I always say too. I live in Minnesota. It gets icy. We have a lot of people that fall, slip on the ice. Is that really what it is? That's not even close to what it really is. Domestic violence. 10 times everything else put together. I know, it's not what we think. It's for sure not what I'm diagnosing, right? Is my mic on? Yeah. Right, I think sometimes they don't admit to it. They come up with some alternative reason of what's happened, why they come in. But I think a lot of times they don't come in, too, in general, for fear. So at any rate, for what it's worth, domestic violence is by far and away the number one cause of trauma in pregnancy. I know, it's sort of a little bit shocking, really, the numbers on that. I'm going to talk about basically the basic management of a trauma in pregnancy, but then we're going to come back at the end to evaluation for domestic violence, also kind of as a little sidebar. So first of all, right off the bat, if a patient is pregnant and experiences a trauma of some type, the pregnancy itself is going to complicate the management of the trauma. One early consideration is, are you considering this a minor or a major trauma, which has something to do with the timeline for a fetal evaluation, basically. That's probably the big key piece of this. So if you're considering this to be a major traumas require 24 hours of monitoring. Minor traumas require 4 hours of monitoring. So what counts as a minor? It's a little bit arbitrary, but anything that causes a direct blow to the abdomen automatically is a major. Everything else you're going to kind of consider. If it's a car accident where the seatbelt jerks them, you know what I mean, where they have a little bruising from the seatbelt, that counts as a major. So anything that you're calling like a major trauma requires 24 hours of monitoring. If it isn't, like people slip and fall on the ice and go down on a knee, that sort of thing, those are all minors. Minimum for that, 4 hours of monitoring. So initial assessment, is this a major or minor? There are some changes physiologically in pregnancy that are going to impact our management with the trauma. Assessments are different during pregnancy. Lab test values are different. Physiologically, we're different, so as far as even like treating injuries. This is why the ER hates the pregnant girl. They don't want her down there. If she has a positive pregnancy test, they want her to go up to the unit. I don't care if she's half decapitated. They want her up, they do not want her. I know, right? Send her upstairs. The problem with that, of course, is that we have no skill set really for dealing with the trauma part of it. So, thank you. Thank you, I appreciate that. And you're all gonna see how lazy I am that I had to ask for a stool. Oh, thank you. Appreciate it, thank you.
You're welcome.
Thanks so much. I don't need to sit yet. What happened? Are you making fun of me? Oh. Oh my God, right? That would be nice. Wine? Where's my wine that goes with it? So at any rate, this is why we are no good at trauma stuff. The trauma people are probably not great at OB stuff. So there's going to have to be some collaboration now, which we are really not great with. And I think I kind of feel like I even kind of get this because I prefer if I can just manage the patient myself. Get out of my way. I know what I'm doing. I will deal with it. When you have other people weighing in on things, I don't know, it makes me nervous. Do I for sure trust what you're thinking? Do you know all the things I know about? You know what I mean? I don't know. I feel like that's where kind of the conflict comes in sometimes. We all think our own things are the most important things, and the things I poo-poo are certainly not the same things that the trauma people poo-poo. Even I had a patient who was an ICU nurse. This struck me particularly at the time this happened. A patient of mine, ICU nurse. At the time I saw her for her annual exam, there was an OB patient in the ICU. It was not my patient, but the patient was intubated. It was a mess. Over in the ICU, delivered. My patient, who is now seeing me for her annual, says, we hate having OB patients over in the ICU. I'm like, I know. We all know that. Well, we don't even see why she should be over there. She says, she should be over on labor and delivery. She's postpartum, she says. I'm like, what the hell? She's intubated. She says, who cares about the intubation? Respiratory therapy deals with that. Like as if that was nothing, right? She's got all these lines. She's laying there half dead with the tube down her throat, and you want me to take her over to labor and delivery because RT deals with the intubation? Oh my God, as if. I said, girl, no. She's like, well, that's why you guys have to keep coming over checking the fundus. It's all about the fundus and this concern of the fundus while she's laying there, as I say, half dead. It was just interesting what people perceive as concerning, where to me, my God, she's intubated. Oh. And to her, there's nothing to that. What about this? I was going to say nobody dies of the fundus, but I guess people could potentially hemorrhage from the fundus. But at any rate, our perception, right, it's our comfort level, what we feel comfortable doing. So some collaboration for sure between the ER, the OB staff, the trauma surgeon, the perinatologist, potentially depending on gestational age here. Cardiovascular, the big cardiovascular change, the heart pump's different when we're pregnant because of all the extra blood volume that we have. So it expands more, it contracts more, it empties more when it contracts. So some major cardiovascular changes that will impact even things like EKGs look different when you're pregnant. So again, that's why the ER doesn't like it. Is that like okay, normal one for pregnancy? Pulmonary changes as the uterus is growing, it puts pressure on the diaphragm, right? It actually shrinks our lung capacity, so we have less residual capacity. Big hematologic changes. By term, there's about 50% more blood volume, which is mostly made up by plasma volume. So we make a ton of extra plasma. We've got a bunch of extra volume because it has to go now to support the pregnancy. But meanwhile, our red blood cell production can't keep up with that. So people tend to run a little bit more anemic during pregnancy. Also, all of this blood supply going to the abdomen, so if there's any traumatic injury to the abdomen, it breaks blood vessels, people can exsanguinate from that. All of our veins are huge, dilated up to make room for all this extra blood volume, so if you get a broken blood vessel, there's a lot of blood loss potential with that. So that has impact. Our white blood